past 10 o'clock. We're already up to 81 degrees at the KRIM studios on West Frontier. Hope you're having a good morning out there. This morning on KRIM's Community Spotlight, we're talking, as we do once a month, about the Payson Regional Medical Center, or Banner Payson Medical Center, excuse me. I've been in Payson too long. But at any rate, we have, once a month we have folks come down and let us know a little bit about what goes on in their department. And I'm kind of excited about this morning because we're going to be talking physical and occupational therapy today. With us in the studio, we have Spencer Edwards and Trevor Chitwood, both are physical therapists, and occupational therapist Angie Prock. And now, first of all, thanks to all three of you for coming down and being with us today. We appreciate you being here.
Thank you for having us.
Sure. Now, obviously, when it comes to physical therapy, this can go a lot of different directions depending on what's going on. I know myself, as far just my personal experience, I had shoulder surgery about 12, 15 years ago at a glenoid labrum interruption, and ended up with 7 months of physical therapy, and it was. I invented some new dirty words. It was a wonderful thing, but I have to say, my shoulder is better now than it ever was. So I mean, there's a lot to this. So depending on what kind of injury someone had, what kind of surgery they had, that type of thing, obviously this can go a lot of different directions. So Spencer, first of all, I know with Payson demographics being heavily weighted towards retired folks. I mean, are you finding most of the workload kind of focused in that area? I mean, as far as maybe knee replacements, hip replacements, things like that? Or?
Absolutely. Our average patient age is close to 65, 70 years old. We
Right.
see a lot of total knee replacements, a lot of total hip replacements, chronic low back pain, chronic neck pain. We are pretty good at helping people out who are older and have some chronic pain.
And at least I know with my experience, y'all kind of ease people into things. I know with the shoulder surgery, I got these like jumbo size rubber bands that I had to just work with, and it seemed like a kind of an easy way to get into it to begin with. So it's not necessarily, what's the old adage that I think my mom always said, it's got to hurt if it's to heal. It's not necessarily always like that.
Absolutely. Patients come in all the time and they'll say, I need to push through this, no pain, no gain, and that's kind of an outdated philosophy, especially in terms of physical and occupational therapy. We don't want it to hurt. We want it to be pain-free and slowly build up and strengthen until you're back to doing the things you want to do.
Me too. And now, in looking at some of your bio information, Trevor, I see that currently about 60% outpatient physical therapist for Banner Select Physical Therapy and 40% inpatient physical therapist at Banner Payson Medical Center. Explain the diff.
So I have kind of a cool role with Banner where I do part of my time outpatient, and then I'm also the physical therapist for the hospital. And the roles are quite a bit different. So in inpatient, my job is to look at basically discharge planning and look at patients' bed mobility, their transferability, which is getting up and down, and then also their walking ability, and then determining if they're safe to go home at that point or if they need to go to a skilled rehab facility for a little while to get strong enough to be safe.
Now, does this include like a little assessment of what their home environment looks like?
It does. Yeah, and in some cases we will go to the home and actually assess it, but most of the time it's through asking questions.
Sure. I mean, do you have stairs? Do you have that
exactly,
kind of stuff? Right?
Yeah, single level home, multi-level stairs, looking at their bathroom. Do they have handrails in there? Is their toilet seat elevated?
Right.
Can they get a wheelchair in there? Stuff like that.
And going along with that, I would, and again, I'm just thinking out loud with you, but I would assume, and of course you know what they say about that, but I would assume that with our demographics being heavily weighted towards retired people, that it's sometimes a lot more than just joint replacements or injuries. You got to deal. I mean, there's physical therapy when it comes to recovering after a stroke and things like that too. So I mean, this can go a lot of different directions for you.
Absolutely, and one of the unique things about stroke is they have something called intense inpatient rehab, and stroke is a qualifying diagnosis for that. So instead of going to a skilled nursing facility where you'll get an hour of therapy per day, in intense inpatient rehab you can get up to 3 hours of therapy per day, and the stays are usually a little shorter, like maybe 2 weeks or so. But the goal is, within that first 10 to 14 days, Stroke patients get a lot of recovery in that time, so they want to optimize the therapy during that period and do, the most amount of therapy they can get to ensure.
This is, you're basically sometimes having to retrain parts of the body how to do different things, right? I mean, it's like the muscle memory is gone.
Absolutely.
Huh, wow, interesting. And Angie Prock with us also, you're an occupational therapist, so I'm assuming then that this also goes into how this all applies to getting back into the workforce again.
That's a really good question. A lot of times people do assume that I will work toward getting people back to work. Think of it more as the occupation of living. So the things that occupy your time during a typical day, your roles, your responsibilities. So if you have an injury or have a disability that's affecting your ability to perform those things, occupational therapists help you to get back to that. So for instance, a person who's had a stroke, PTs and OTs often work closely together. The physical therapist may work more on the mobility and the strength of that lower body area. The occupational therapists often work on dressing, bathing, fine motor skills, gross motor skills with the arms, and the things, and cooking, things like that.
I was just going to say, how to fix a meal for yourself. Especially
Yeah.
a lot of these folks, I'm sure, are oftentimes by themselves at home, and how to be able to take care of themselves all the way around.
Absolutely, and teaching spouses and caregivers, okay, this is how you can help your loved one. In terms for myself specifically, I'm working on a specialization in upper extremity therapy. So working for people who've had, or working with people who've had wrist fractures, hand injuries. I do also work with shoulders. The physical therapists work with shoulders and elbows also. So we overlap a little bit in our facility. I tend to really look at more, rehabilitation post-op and helping people with, stroke recovery and things like that.
And at the stroke recovery, I mean, I've been around a few people that in my family that have had strokes, and man, I mean, it sometimes is amazing how quickly some different things can come back, and other things don't come back at all. I guess it just depends on what part of the brain was affected by the stroke.
Definitely. I think as soon as someone comes to see me for, rehab after a stroke, they'll say, well, I really have trouble, picking up my medication off the table because my right hand won't coordinate. I can't get it to do what I want. Well, those are the very things we look at doing in therapy, is stimulating that part of the brain by performing those tasks. And I help guide the person in, what tasks can really help improve that. And usually it's repetition, functional, and something that's challenging.
What's the, Spencer, what's the biggest misconception people have when it comes to physical therapy? I mean, I'm sure you've run into something time and time again where people were assuming one thing, but actually reality goes in another direction.
There's plenty of misconceptions. I would go back to what we were talking about earlier, is that it's going to hurt. If you're coming in for physical therapy, we are doing everything in our power to make sure that you are not hurting. That's the first goal, is to get you pain-free, to get you, and then we can get you stronger, then we can get your range of motion back so that you are feeling better. So that's one big misconception.
What's the average, and I know that there's a lot of variables here, but on the average, what's the average length of time that someone goes through physical therapy?
I think the average within Select Medical, which is a company that we're a part of, is about 17 visits, which would average out to roughly 3 months. And there's a huge variance there. Sometimes patients come in twice total and they're great. Other times patients are here for a year, depending on their acuity and what kind of condition they have.
And Spencer, when it comes to, again, physical therapy, as we mentioned, it can go a lot of different directions, but is there is knee replacement the big thing that you deal the most with? I mean, is there one area that you just see a lot of cases of?
It depends on the clinic, but in our clinic especially, we see a ton of knee replacements. Hip replacements, and back pain.
One of the things that, just on a side note, I know I've known a couple of different people that have had knee and hip replacements. My mother-in-law, who we care for, had both a knee and a hip replaced, and prior to that, I mean, she was in a lot of pain, hunched over, using a walker to get around, and her whole, mental focus really kind of went downhill for a little while, because I think she, maybe just a lot of, if nothing else, subconscious thought about how, well, life's coming towards an end, and life stinks and blah blah blah. But I was amazed by two things, and one is how quickly they get you up and moving right after these joint replacements, because it seems like a pretty brutal amount of work that's suddenly done to your leg or hip or whatever, and how like sometimes within the same day or the next day you're up walking around. I found that astounding, but also how quickly her in my mother-in-law's case, her quality of life improved, and it really affected her attitude in general, and I would assume that that's probably something that you see a lot of, where people have been through something like this, and that basically the world sucks, and kind of a sort of attitude, but afterwards with a little bit of physical therapy, that can really change a person's mindset completely as well. Does that make sense? Am I right?
Yeah, and one of the unique things about me that's a little bit different maybe than other PTs is that I started as a psych major. And
Wow.
I had a volunteer opportunity at the VA in Tucson, and I started volunteering in physical therapy, and I saw that you can have a huge impact on somebody's mental health and quality of life by restoring their function, because then they're able to go to social events with their friends, or maybe play sports that they weren't able to play before. And so that's kind of what drew me to PT, is that there is a huge psychological component to it. And one of the things we do when we're building goals is asking the patient, what are some things that you're not able to do now that you'd really like to get back to? And then we structure our exercises to try to help them, get back to those specific activities.
And I would again assume that the same is true when it comes to occupational therapy, in that you probably pretty routinely see a big change in a person's attitude after they're able to get back to fixing a meal for themselves, or taking a shower without anybody helping them and things. I mean, getting that independence back has got to make a big difference in people's mindset.
Yes, for sure. People will, you wake up in the morning and you realize I still have this injury, and it can take a toll on you emotionally.
Sure.
So as you start to, wake up days and days ahead, and you notice, oh wow, I can move my wrist better today. I can hold a spoon and stir, soup better. It really, it helps you to feel better. People can say, oh, you look better, you're doing better, but to actually see changes occur really helps people emotionally. I see that often, and we'll do progress notes about once a month or every 10 visits, and that's a great opportunity for a person to look at, let's say, their grip strength and how it's changed after a wrist fracture.
Mm-hmm.
They can see, wow, I've gained 15 pounds of grip strength. I didn't even realize it. So it's a nice way to reflect on how you're coming along, or it could go the other way. Well, we're not quite seeing the changes that we expected yet, so let's try something new and do something different. So
What got you, Angie, what got you into occupational therapy to begin with? What made you choose that?
I thought I actually have my bachelor's degree in communication disorders, which is a prerequisite to becoming a speech language pathologist or a speech therapist. And I was working on getting my volunteer hours for school, and a friend of mine who was an occupational therapist, I happened to see her across the room working with someone, hands-on working. I can't remember exactly what they were doing, but I thought, I really like that better. I'm going to do that.
Yeah, that makes sense.
Yeah, so.
And Spencer, what about you, Spencer? I mean, what got you involved with this to begin with?
When I was 10 years old, a neighbor kid moved in. His name was Cameron, and we would play out in the streets and we would run around, and I noticed when he would run, he would kind of shuffle his feet. He wouldn't pick his feet up, and I started bossing him around a little bit, and I said, pick up your feet and run faster, and he did, and it felt good, and so I became a PT.
Wow, that's interesting. That's cool. And gotta keep on asking here. What about you? I mean, what motivated you to get involved with this to begin with?
I think volunteering at the VA and working with veterans and stuff, which is a huge passion of mine.
Mm-hmm.
I just experienced some of the emotional part of it,
Right.
The psychological impact of it, because I was a psych major and I was really focused on that. I guess I didn't realize how much having physical disabilities affected people emotionally. And I was also a sports medicine trainer in high school,
Oh, okay.
and I really liked it. And I thought, this was another level of doing that, but kind of being able to look at someone's, not just in sports, but people in everyday life, and trying to help improve their quality of life.
And I would assume, this is going to be really gratifying for all three of you, in that, you really see the fruit of your labor on a daily basis and the difference that it's making in people's lives. That's got to be pretty gratifying.
I just had a patient yesterday tell me that she was able to wash her hair for the first time in about a year.
Wow.
And
Things you
seems
take
like
for granted, you don't
something
even
so
think
simple.
about.
Yeah, but to her it was amazing, and that's what we talk about, are just the little things that they start to notice. And that's why we don't want to set our goals too lofty, because it takes such a long time to get there. But if we set these small goals and you have these little victories on the way, it helps carry you through, to that final goal of being able to take care of yourself completely.
Yeah, get your independence back, not having to rely on other people to do things for you, and that's got to make a big difference. Very interesting. So, about roughly, how many patients a week do you deal with here in Payson?
We average 8 patients a day, so 8 times 5, so about 40 patients a week.
Right.
But there's a range. And on a busy week, up to 60 patients.
So, and the same with occupational therapy as well?
Yes, I probably average around, I was actually looking at it the other day, probably 28 to 32. I work 4 days a week right now, so,
Right.
yeah.
Wow, that's interesting.
Yeah.
So, now are you, as an occupational therapist, are you, I know we were talking at the onset here about doing assessment in people's homes and things like that. I would assume the same is true with occupational therapy as well, and sometimes you got to take a look at what they're dealing with.
Yes, most of the time it's an interview scenario in the clinic, because we are doing outpatient therapy.
Right.
So interviews, maybe, seeing pictures, people may take measurements. I have gone out to homes in the past and looked at equipment modifications. There was a person with a spinal cord injury that needed some help with environmental modifications. So I went out and did that. Depending on the setting you're working in an acute rehab setting that I think you were talking about, Trevor, is, often the therapists will go out and look at the home for the person so that they know what they're returning home to, and they gear their therapy toward those discharge goals.
Well, spinal injuries, that could be tough.
Yeah.
So when you talk about environmental augmentations, what are some of the things that typically you're needing to do?
Most of the time, if it's a person who's needing to be in the wheelchair, we'll look at the width of the doorways, the height of the countertops. Especially with a spinal cord injury, it's a long-term plan you're looking at most of the time.
Ramps instead of stairs?
Yes,
Yeah.
If it's something, a person with low vision, or a person who, you'll modify more lighting. You might make sure they don't have rugs that'll trip a person up. I, as an occupational therapist, look at modifications for handwriting and cutting food and things like that. Just little tools you can use that make your life easier. Yeah.
One of the things in our family, I talked a little bit about my mother-in-law, but we also were kind of a key caregiver to my mother in her last couple of years of life. And things like chair lifts, that enabled her to stay in her home where she would have either had to been relegated to just staying on the ground floor, or getting rid of her home and moving somewhere else. Sometimes simple things like that can make all the difference.
Absolutely. Yeah, and personally speaking, my stepdad, he has Alzheimer's disease, and my mom is fortunately able to keep him at home and take care of him, because he's bigger than she is, but with a chair that helps him stand and with certain equipment, she's able to do it and do a great job at keeping him healthy and keeping him at home. So it's great.
Well, I tell you, and towards the end of my mom's time, what was it called? A Hoyer lift. Just getting her out of bed and into a chair. Simple things like that she couldn't do on her own still gave her a little bit more of a sense of normalcy, and that she could at least sit up in a chair and watch TV or something like that. And without those tools, that would have been a much more difficult bunch of stuff to deal with.
For sure, yes.
And now, and Spencer, when it comes to various apparatus, are there other things that sometimes are sent home with a patient to help with physical therapy? I mean, is it, are there other tools and toys like that?
Plenty of tools. We don't often call them toys, but you can call them
I hear you. Good choice, by the way.
Canes often. We'll
Right.
send people home with canes often. That helps with balance, helps with leg pain. A walker if the cane isn't enough. There are cool little things where if you have trouble bending over to put your socks on or lift your leg up into bed, there's a leg lifter. There's a sock aid that helps you put your socks on. There's a tool or toy for basically any condition.
Sure, I need a butt lifter.
I use toys in my rehab. Like, my room looks like a kindergarten classroom. There's golf balls and, like, I don't know, everything. We use tweezers in my rehab for fine motor skills.
Wow.
Yeah.
Oh, that
We
sounds-
actually use toys in mine.
Sounds like a fun place.
It's very fun.
I want to go visit her. And now, as far as again, with a lot of the folks being retired and here in Payson, and the need for some of these other things like canes or the leg lift and different things like that. Are most of those things covered by like Medicare and insurance, things like that? And are there some folks that, because maybe they don't have insurance coverage, have to get a little more creative in how to acquire these things?
Yeah, so some of the little devices like, sock aids and stuff most likely aren't covered, but something like a walker or a wheelchair,
Mm-hmm.
Medicare has rules about how often they'll pay for an assistive device, and I think it's one device every couple years, but I could be wrong, we'd have to look at that, but yeah, so there are other places, like if you go to the Humane Society thrift store, a lot of people donate walkers there. Some of the knee scooters, they even make something that looks like a peg leg. It's called an iWalk 2.0, which I think is an amazing thing for someone with a lower leg injury, like an ankle fracture or something like that. So people will use them for a while and then donate them. So there's lots of different places in town you can purchase them, at a very discounted price and then donate them again. I think the Payson Senior Center also loans out
Right.
devices, and then you can return them when you're done with them. So there's a lot of resources, and we try to help if patients do have some
So
financial
you kind of
hardship.
help connect the dots with the resources. I like that.
And I love going to thrift stores, so I usually look and see what they have. I'm like, oh, I saw one of those at the Humane Society thrift store, so you need to
Right.
go get it or something.
Very interesting. Okay. Now, as far as folks that are maybe having just maybe they're getting a little maybe bone-on-bone action in the knee or something like that, and they don't really want to have surgery. Are there some instances where people can just through physical therapy maybe improve the condition of some of these things, or is that kind of just foggy thinking?
I think sometimes people develop some odd gait mechanics when they have pain, and their muscle timing can get off, and so you can get some shear forces in joints, which can cause some irritation. So one of the things we focus on is restoring range of motion to get the joint to move normally, and then working on timing the muscle contraction so the right forces are going through the joints when they're supposed to,
Right.
and we can get some good amount of relief by kind of doing some retraining that way.
And Angie, when it comes to occupational therapy, again, I would assume that, excuse me, that I have wonderful allergies. If you know anything I can do about that, let me know. But if, what are the most common things just being able to do things like to be able to wash your hair, to be able to, get from point A to point B in the house? I mean, are those typically the most common things that you're dealing with?
I would say because of what I specialize in more physical, impairments. So I do a lot of shoulder, people who've had total shoulder replacements, rotator cuff repairs, which the physical therapist, we overlap there. My biggest group is probably the people who've broken their wrists, tendon lacerations in the hand, finger fractures, a lot of elbow injuries, and so I find myself working more in that on those kinds of things, and so I incorporate those functional activities into my rehab. So for instance, if somebody needs to be able to, with their wrists, they need to be able to scrub their kitchen cabinet, well, we actually when they're ready, we'll work on doing that in the clinic and doing things that are similar. There are other settings I've worked in where, I worked as an occupational therapist in a hospital and help people just go into the shower and learn how to bathe themselves again after a stroke. And so there are occupational therapists that work with pediatrics and help with children who have autism and developmental disabilities. So that's one of the nice things about my field, and I guess all of our fields, is that depending on your interest level, you can really expand to any area and work with people and help them get better. So
Okay, one last question, because we're just about out of time, but this is strictly a self-serving question. My wife and I both spend an inordinate amount of time in front of computers every day, and are starting to see perhaps the beginnings of a little carpal tunnel challenge. From what I understand, there are different types of exercises that can be done to get around that without having to go down the surgical route. Is that true?
yes, usually if you catch it within, when it's not gone on a year, typically you can conservatively manage it. Wearing a wrist cock-up splint at night is one of the first lines of defense, I guess. It helps position the wrist into a good position to help decrease the compression on the nerve in the wrist. Watching your posture. So much of our injuries come from poor posture, especially with computers. So, maintaining the head in alignment with the spine, and looking at the setup of your computer. If you're leaning over on the couch, you're probably going to end up with some pains, but if you're sitting, ergonomically at a desk, you're going to have less trouble.
Makes perfect sense.
Yeah.
And if people want to find out more, now do they have to be referred to you three from their primary care physician? I mean, can people just come straight to physical therapy or occupational therapy, or how does that work?
Really depends on the insurance. So if it's a federal payer, then usually, they have to have a referral from primary care. If they have a private insurance, then we can be direct access. It always goes back to the physician to sign off. It's just how you initiate the care. It either comes from the top down, from the physician to us, or we initiate the care and then the physician attests and signs off, that they approve it.
Makes sense. We've been talking this morning with, again, Spencer Edwards and Trevor Chitwood, both physical therapists, and Angie Prock is an occupational therapist, all from Banner Payson Medical Center. Appreciate y'all coming in this morning. This has been interesting. I've got only a couple of thousand more dumb questions, but we'll save those for next time. Anyway,
Thank you very much.
Thank you.
Absolutely my pleasure. Thank you for being with us. And we're going to get you back to more of your favorite music. Have some tunes coming up from Red Rider, Rita Coolidge, Hall & Oates, The Doors, and more. But first, a quick look at Rim Country weather.